just finished a long surgery. So I will go ahead and turn this over to Dr. Schwartz right now.
Everyone, we're going to thank you. First of all, thank you for sending these questions in. We just had a really long day of surgery. I might just fall over here while I'm talking, but I'll try to stay upright. So Christina was kind enough to type these out, so I'm going to just go through these questions and talk about some things. First question is, what did the standard of care meeting at the FDRS meeting in Baltimore focus on? And so we're not really, we've agreed all not to talk about the actual contents of the meeting, except to say now that we spent 2 whole days, or a day and a half, a lot of hours, with a lot of different people, from physical therapists. Karen Herbst ran the meeting. There were 4 of us surgeons there, and 2, Dr. Bartholomew and Dr. Dean from Ohio, and we talked about the definition of lipedema. So we talked about every little aspect of it: what defines lipedema, what areas are involved, what treatments are available, from physical therapy and non-invasive treatments to surgical treatments. And so we'll be coming out with that soon, and it was a really productive meeting. It was really great. Number 2, what is the maximum amount of liters of fat that I will take out in one surgery? I don't really have a maximum. There's no hard and fast volume that we're restricted to. I found that in larger people, we can take out more fat. In larger people, we can take out more fat with minimal blood loss, whereas in smaller people, they tend to lose a little more blood proportionally than larger people do. And regardless of the size of anyone, we have to be conscious of what's coming out. Is it just pure yellow fat, or is it blood tinged, a little more blood than usual? Because I've been studying, as you all know, that are my patients. Those of you who are my patients know that we check your blood count the day after surgery, and then sometimes a day or 2 later. And I'm going to publish a paper with trying to correlate volumes of tumescent fluid that we put in, aspirate and fat that comes out, and how much blood loss there is, and see if we can figure out some kind of pattern. Something that was brought up, well, I won't go into that. So at any rate, there isn't a maximum. We take out anywhere from, I've taken out as little as 3 liters in one day, somebody up to over 10 liters. So, and those patients are usually staged, everybody's staged, so that 10 liters usually comes out of just maybe the front of the legs or the back of the legs. So it really varies.
Also, I just want to point out that that's fat too, not the tumescent fluid.
Yeah, we don't count fat as total aspirate. I think some other people are saying they're taking 15, 20 liters out. I think 20 liters of anything is a little out there, and that's too much in one day. But we are reporting just fat. I mean, we do in our op reports, and on my study, I'm looking at total aspirate and fat. So those are 2 different volumes. If we have liposuction, then a skin lift, but later we need additional liposuction due to new lipedema growth, can the additional liposuction be done even though we had the skin lift? Yes, absolutely. That can be done. I did that today in a woman who does not have lipedema but wanted more fat placed in her buttocks, actually. So she already had liposuction, then an abdominoplasty, and a breast lift, and then we took more fat out of her back, flanks, and abdomen because she had gained some weight, and transferred it to her face and her buttocks. So yeah, we can absolutely do that. We can revise skin excisions down the road. Some people gain weight after having an abdominoplasty 10 years ago, and they get another abdominoplasty. Some people's arms get redone. Some people have skin excision and then come back and have more fat taken out. So yes, that is very possible. How do we decide where to start with lipo and the number of surgeries required? I just look at each person individually, and it depends on what areas need to be treated and what size the person is, and we estimate the volume of fat. So we typically stage most people doing the front of the upper and lower leg, from the groin all the way to the ankles, in one day. Everything that's not on the operating table, I don't know if you can see my legs, but that would be from here over. So it's more than 180 degrees of the leg. It's more like 270 degrees of the leg. So we'll do most of the leg in one day, and then if you come back and we're doing the back of the leg, there's less to be done, so we can often do another area such as the arms on a day when we do the back of the legs. So with each person, we talk about what your priorities are. Some people are bothered by their abdomen. It's impeding their movement. If they have a really large abdomen with a lot of excess skin, which is called a pannus. Some people want their torso treated first with back flanks, abdomen, and a tummy tuck. Most women with lipedema, though, are impaired by the extra fat in the legs. It affects the joints, as you know. It makes walking difficult. I have a lot of patients who can't walk around the floor of their warehouse where they're working, or a nurse who can't do her 12-hour shift because she can't stand up. So usually legs are priority. Legs and arms are what impair most people the most, or impact most people the most, sorry. How soon after knee replacement surgery can lipo be performed if it needs it in that area? I think you should probably wait 6 months, but I would check with the orthopedic surgeon. I've never actually done liposuction around someone's knee replacement that close to surgery. I've done it around a lot of patients who have already had knee replacements years ago, and it's not an issue at all, but I would check with the orthopedic surgeon to see, and I would think 6 months minimum is a good idea. Is there a max amount of time we recommend between surgeries, i.e. legs done anterior and posterior, but arms and body done further down the line, say a year or so later? There's no maximum time. There's a minimum time, and usually we like it to be a minimum of 4 weeks, and sometimes between 4 and 8 weeks. And really, the bottom line is you're going to lose a couple of points of hemoglobin. You lose a little blood. Most people are fine. Some people get anemic, and we will put you on iron and vitamin C, and we need that to recover. That's one issue. And the other issue is the area needs to heal so that you feel well enough to do another surgery, mentally, physically. If we're doing just the legs and we're doing the front of the legs followed by the back of the legs, and we want to let enough time go by so the front of the legs are healed and not swollen and firm. So it can be a minimum of 4 weeks up to, it could be a year or two, it doesn't matter. The longer the better, really. But with lipedema, you don't want the disease to progress, so, and it's probably most people would rather get all these surgeries done to get the treatment finished and not be constantly having surgery and recovering over a multiple year period. Can I still have lipedema removed from my legs if I've had a greater saphenous ablation on both sides? Yes, you can, and that's good actually. If you have venous insufficiency and you've had your veins treated, I believe there's less blood loss. We were talking about that at the FDRS meeting as to whether maybe people who lose more blood have greater venous insufficiency with a lot of superficial veins under the skin that may get disrupted with liposuction. So again, nobody's lost it's never a big bleeding problem or hematoma, but if you've had saphenous vein ablation, that could only be better, not worse. Does vein surgery have to be done before or after lipedema surgery? Only if you have venous insufficiency, and I always recommend if there's any question, go see a vascular surgeon, get tested with ultrasound, and see whether you are a candidate for venous ablation, and if you are, then it should be done before liposuction. That would make much more sense than doing the surgery and having the venous surgery afterwards. Is it still possible to have liposurgery without using lidocaine, benzocaine, or prilocaine? It's possible, yes. You could be under general anesthesia and have a solution, a tumescent solution with just epinephrine in it that constricts blood vessels and minimizes bleeding. So we put that in every liter, and we put lidocaine usually. If you are allergic to lidocaine, I'm not aware of anybody really being allergic to lidocaine, although I think it's been reported. That could be done, although it may be painful. So I've never actually done that. I would probably do a small test area and see whether the pain is tolerable when you wake up. Because if you have excruciating pain when you wake up because there's no lidocaine, in the area, that might be bad. Dr. Herb says the lipedema is activated at times of hormonal changes. Is it best to wait for lipo until after a woman is done having kids? No, that's not necessary. And lipedema is usually activated with hormonal changes, but that can be, it's usually with the onset of menstruation. With each pregnancy, a lot of women report that they've gotten worse. I've had a lot of patients tell me that they've gotten worse after hysterectomy, and a lot at menopause. So it may be related to estrogen levels. We're not sure. Dr. Herbst is doing research on this. It's not necessary to wait until you've had your children. When we do the liposuction, and there are a lot of questions about whether lipedema recurs or the fat grows back. It's not really clear. Some people have reported that it does come back. We've seen a few people that think their breasts have enlarged afterwards, and that they've gotten new areas. If they treat the legs and don't treat the arms, sometimes the arms are getting larger. So yes, that can happen. But the liposuction has a dual effect. It removes the fat. It also creates some scarring in the fat compartment and solidifies things. So it's less loose tissue and liquid that's associated with lipedema, and so there's less likelihood of the lipedema recurring there. And so again, it's not really necessary or best to wait until you're finished having children. Is there a certain BMI or criteria before getting approval for surgery? There's no cutoff per se, but I have seen a few women who have a very large BMI and have problems with cellulitis in the legs and lymphedema in the legs, and we're trying to get them treated. Dr. Herbst told me about a really good inpatient clinic in Scottsdale. That's a lymphedema clinic where you're inpatient for a week and they wrap you and do compression and massage and get really good results. So you can't really operate on someone that has active cellulitis or really bad lymphedema. That should really be addressed first. However, liposuction itself is one treatment for lymphedema, so that's a consideration also. So really it has to be on an individualized basis. There's no BMI cutoff. Can the liposuction be done if a patient has lymphedema as well as lipedema? So we're talking about that. Is there a risk of lymphedema worsening? There is that risk, but again, liposuction is an acceptable treatment for lymphedema. So we expect the lymphedema to improve after liposuction as it takes the pressure off the lymphatics and they can function better theoretically. So lymphedema is not a contraindication to having liposuction. It just, again, it depends on each person, your degree of lymphedema. Can you still perform surgery to achieve cosmetic value without causing any further lymphedema complications on someone with mild primary bilateral lower lymphedema along with stage 2 lipedema that started at puberty? Sorry, my mind is not good enough to understand that question right. No, I'm kidding. Let me look at that again. Without any further lymphedema complications. Yeah, I mean, if someone has a mild lymphedema in the lower extremities and stage 2 lipedema, I think you could have surgery. Again, I have to just examine someone on an individual basis and see. But yes, I believe that can be done, yes. I've had total knee replacement. Is it safe to have liposuction? I know there's concern about getting an infection in the knee. We give everybody IV antibiotics during surgery and then oral antibiotics afterwards. We're not in your knee joint, so there is very little risk of that. And it's like any other surgery that you would take antibiotic prophylaxis for your knee joint. So we do that. I've operated on a lot of patients with knee replacements, and none have gotten infections. That's a small case sample, but it's not, having a joint replacement is not a contraindication of having surgery. How is brachioplasty performed? Lower body lift, thigh lift. The next question is, can you do a back lift if I have excess skin folds on my back and sides of breasts? Yes. So brachioplasty is removing excess skin in the arm. If you have excess skin hanging in your arm like this, if it's deflated, then you can liposuction the arm. I think the Vaser aids in skin tightening. But if you have a lot of extra skin, especially after liposuctioning the arm, then the skin needs to be removed. You can't just make an incision like this and pull the skin this way. It doesn't address the problem, which is really this. So you need to have an incision that goes on the inner part of the arm up to the armpit and got a little back cut here. So we plan that so it's in the groove of the biceps here. If this is the bicep muscle, then it would be in the groove of the bicep. So when you put your arm down, it's not showing on the back of your arm, it's not on the front of your arm. You only see it when you raise your arm like this, when you're hailing a taxi or tango dancing. So most of your life, you're not going to see it. And it heals very well. It takes a little longer for the arm scar to heal. I found that people have come back in the first year and I think, geez, that scar's not great. I think the skin of the arm is a little unforgiving. It's thin, poor quality. But at 2 years, I see people come back and it's a fine line. It's pretty much gone. So I think the arm heals really well, like the rest of the body. It just might take a little more time. So that's a brachioplasty. A thigh lift is usually, I'll show you on my leg. Make believe my scrubs are extra skin here. So there are 2 ways to do thigh lifts. In the past, there was a groin incision like this and a vertical incision. And sometimes we combined those where we took out skin this way and this way to pull it up. But you find that in most people, the extra skin is in this horizontal dimension. So if you do this on your inner leg, that takes care of most of the wrinkly skin in front. And it's also a lot safer to make an ellipse or a fusiform pattern that goes like this, up to the groin, down to the knee, on the inner back of the leg. You end up with one line in the inner back of the leg, rather than making these groin incisions, because when you do this, you need to sew this flap to the bone of the pelvis, and it's risky. One complication is labial spreading. If it catches or it comes apart, the scar can spread, the labia can spread. It's impossible to fix that. So most of us are getting away from this incision. I did a thigh lift today and did just this, and it looks great. So I think it's a really great technique with very little risk. You can do a lower body lift, which is you can do an abdominoplasty in front. You can do a lower body lift, which is a back lift. So interestingly, in front, the skin is loose in the abdomen, and you make an incision down here and lift this up and pull it down and trim it. In the back, it's the other way around. The back skin and the flank skin is tight, and the buttock skin and thighs are loose. So when you have a body lift, it's not to remove loose back skin, it's to lift the butt and outer thighs. If you need, there's another question about a back lift in here. We also do back lifts where if somebody has a lot of extra skin up here, you can make a curved, if you're looking at me straight, if this is my back, scars would be like this on your upper back. You can also, if you don't have a lot of extra upper back skin, but you have extra skin here on the sides of the breasts, we can do a lift that just is a vertical line here. It goes into the underarm and then down here. And you can do an extended brachioplasty. So you can go on the arm, make a little Z, and then go in down here. So you can take out the extra arm skin along with this skin and this skin lateral to the breast here. So that's a good technique. I dropped my questions. And so that's a brief nutshell of how those lifts are done. Next person says, I've had 4 unsuccessful, semi-successful lipos, and then had a baby 4 months ago. It's been 2 years since my last liposurgery. I can already tell places that have grown since these surgeries. How long do we recommend waiting after having a baby to have surgery again? I think you need to stop breastfeeding whenever that is for probably 3 months, and it would probably be a minimum of 6 months, but better, I think, would be a year to wait after your last baby. Is it possible to just have ankles defined by having the lipo fat removed, or do you need the whole lower leg debulked? No, we can do select areas. We could do somebody's, if you just want your ankles done, we can do your ankles. If you wanted just your knees done with the extra fat on the middle knee or above the knee, on top of the knee, we could do that. We can do the circumferential ankle. Yes, you can do that. How can we tell if most of the lipedema has been removed after surgery, or how can you tell when more surgery is needed? We take out all the fat that we can take out. We take out all the fat that comes out. When you get to the end of an area of removing fat, it starts to get bloody. So it starts to get bloody and no more fat comes out. So that's how we know that all the fat's coming out, and we're constantly feeling it with our other hand while we're suctioning. I'm left-handed, so suctioning and feeling, and I feel with both hands, and I feel for symmetry in both legs, and pinch the skin in all the areas to see that it's a similar thickness on both sides. And so, but here's the thing, you can't take the, one of the doctors at the meeting presented turning the cannula up against the undersurface of the skin and rubbing all the fat off the skin. I don't think you can do that with liposuction. So we've always been trained that you don't do that with liposuction. I don't think it's a good idea. You need to leave a centimeter of fat under the skin for contour and padding. And if you remove all the fat from the skin, then you're gonna have skin sticking down the muscle lining, and you get contour deformities. It scars down. You get dimpling. It's really difficult. So I've not done that in anybody. I've never done that, and most people are getting really good results. Sometimes, however, lipedema recurs, although we think that's really rare. A lot of people have concomitant obesity with lipedema. So, I have a lot of patients come out and say, we went out to eat last night and had whatever, bad food, which I, by the way, like to eat myself. But I would just caution you that we're doing the surgery, you're losing weight with the surgery. And by the way, fat weighs about 2 pounds per liter. So if we take out 10 liters of fat, you should lose 20 pounds if you adhere to a low inflammatory carb, low inflammatory diet, maybe a keto diet. I don't know that that's actually very healthy, but complex carbohydrates, vegetables, fruits, chicken, fish is good, low calorie. If you adhere to that, you should really lose weight. If somebody has 10 liters of fat removed and comes back in 3 months for surgery and they weigh the same, then they probably gained 20 pounds eating, or they just haven't lost their weight yet, hopefully. But you really need to be conscious of that. And so how do we know if more surgery is needed? You need to look at areas, and if they're getting larger, or if there are areas that bother you, then that's an indication to do more surgery. Status post anterior and posterior liposuction of the legs. I now have hanging skin on my thighs. Can the dimples and cellulite and uneven skin tone be smoothed out with the thigh lift? Yes, I think it definitely can, and it is. And we talked about that. That's from one of my friend patients. So yes, we definitely can do that. I think the skin will smooth out with the thigh lift. And by the way, when I do the thigh lift, I do more liposuction. I do that because I can smooth out the areas that are dimply a little more, and the area that I told you we're taking out inside here, now we can empty that area out super aggressively. In that case, I will take a cannula and try to remove every fat cell in that area, because we're taking that out and we're moving, good skin to good skin and closing it together. So you don't need to leave fat under the area where you're moving 2 other layers together. So I think the additional liposuction with the thigh lift helps also. And page 2. Somebody says, I've had surgery, but my ankle still hurt. Do you think it is the lipedema or not enough was removed? Also, I've seen that in some, you remove that big lump just below the ankle on top of the foot. This wasn't removed and it's still painful. Is that considered lipedema? I think that is kind of diagnostic of lipedema. There's a little fat ball that I thought was a lipoma, and I had a patient consent to me make a little incision to take it out to see if it was a ball, and it wasn't. It's just fat in a compartment. And Karen Herbst said, when I asked her about it, She thinks it's just fat in a small area, so it feels like a ball. So she was right, of course. And I sent her that lump, and she looked at it, and it looked like other lipedema fat with almost like angiolipoma with blood vessels. So that fat in the foot, right by the outer ankle bone, the lateral ankle, right below that, is lipedema fat. So I do routinely remove that, and if you still have it and it's hurting, it could easily be taken out. And if that's the only area that needs to be taken out, it's super simple to do that. You can do it under local anesthesia very easily, and remove that. What have we seen as a return rate of lipedema post-op? Do we need to do touch-ups later on? How long down the road? Which areas come back the most? Arms, abdomen, upper legs, lower legs. Is this from you, Christina? Most ladies. So Christina said most ladies complain of the mons pubis growing and also are happy to report that the breasts grow. Yeah, we have heard that a lot of women are saying that the breasts grow. The mons can grow. Maybe the mons gets bigger because if you don't include that with the abdomen, you get dependent swelling or dependent edema where gravity makes that area swell. I don't know that more fat grows in that area, but we do routinely liposuction that area when we do the abdomen if it's too prominent. So, and we can always go back and do it again. I don't know if anybody knows what areas, nobody knows what the return rate is. I think it's only a few people out of millions that have said the fat is regrowing. We do touch-ups if you need touch-ups, so we're happy to do them. And I would wait at least 6 months to do a touch-up, preferably a year, because you want to heal and let the skin contract and do what it's going to do and be fully healed, or otherwise we're touching up post-operative swelling, and that doesn't make sense. You're just going to create more swelling, and it's not necessarily fat, it may just be post-op swelling. Will the legs of some of the post-op photos remain that small? It seems like they're small right after, but then they puff up. Well, yeah, people usually on the day after surgery are pretty small, but then you get swelling from surgery, and that's because you're traumatizing an area. You have cells that repair injury coming into the area, you have fluid formation. So that's why it's so important to do compression, lymphatic drainage. Pump is great. There's a question here about the FlexiTouch pump. We do recommend that, or similar models. The FlexiTouch is expensive. There are other models that are less expensive, but I think they're great to have at home and use those a couple of times a day on yourself in combination with lymphatic massage and compression. Do we follow up with patients over the years to keep track of how many surgeries remain successful? Yes, we are doing that. We're contacting people, and we spoke today. We had a conference call today with Dr. Herbst and myself and some other doctors with United Healthcare about insurance covering this, and we all have agreed from the FDRS and from this that we're going to pool our data and send out a standardized questionnaire to see whether we can determine when it comes back, if and when, and how much. So yes, we are doing that. Up until now, though, it's been individual people just treating lipedema, and there are no big studies of a significant number of patients to be able to say statistically comes back in the legs at 10% of the time at 5 years. We just don't know that yet, but we're working on it. Why does the tissue swell after surgery? I think I just answered that. So trauma of surgery, cells come into the area, fluid comes into the area. How can you tell the difference between swelling and regrowth of fat? Swelling should go down over the next 6 months after surgery, and regrowth of fat will be soft, fatty tissue that feels different than swelling. Swelling's usually, you can get a seroma, which is fluid, and when you press on an area, you get a wave. That's a seroma, but swelling from surgery is usually firm swelling, and that is different than fat, which is soft. I have a complicating illness, which is chronic fatigue syndrome. This is a long question, and my voice is going up. My tests have shown a lot of inflammation.
I think will surgery, will the chronic fatigue make surgery or make the recovery harder for her?
We've had a lot of patients with chronic fatigue, and they have not had more problem, I don't think. So I think I would talk to you individually. I'm happy to talk to you and see how severe your chronic fatigue is and what you're doing about it and what your surgical goals are also. But I'm happy to talk to you about that. How do we take out hard lipomas from lipedema as well as Derkham's disease, Vaser, or excision? Sometimes if there are soft lipomas, I can break them up with a tiny Vaser probe or a tiny liposuction probe, and that's preferable. However, other times, if someone has painful nodules, I have them show them to me. If they're really discrete painful nodules, I make a little incision over and we can pop those out, and then you know that you got rid of it. So that's probably a better, more sure way to get rid of painful nodules. If you don't want a bunch of little scars all around, we could certainly try to break them up, and if we can't break them up, then we'll make a little incision and we can pop them out. Can I have surgery if I have cellulitis? Can surgery cause cellulitis? Answer is yes and yes. No and yes. So if you have cellulitis, we don't want to do surgery because cellulitis, you already have a skin infection. When we put epinephrine in the solution, it decreases the blood flow to that area, it decreases bleeding, but it decreases healing, so to speak, because if you have, we're further compromising the blood flow to an area that's already infected. So no, we wouldn't do surgery if you have active cellulitis. It needs to be resolved. And if there's cellulitis associated with lymphedema, then I think you need to go to a lymphedema specialist and have non-invasive treatment with massage, compression, pump action to try to resolve, and antibiotics to try to resolve the cellulitis. Surgery can cause cellulitis. I've had a few patients get little areas. I've had a few patients get a small breakdown in the lower leg. One patient got cellulitis in her lower back, which was complicated by a lot of other factors. But the lidocaine we use in the tumescent fluid is antibacterial. We give you IV antibiotics, and so very few people get infections or cellulitis after liposuction for lipedema. What effect does Vaser have on the lymphatic system? It has no effect, really. We've done 170 patients since July of 17. No one has had lymphatic insufficiency following Vaser liposuction. The protective part of this is not the wall or the water-assisted jet or any technique or the power or the Vaser. It's the tumescent fluid. So when you inject fluid, the fluid hydrodissects the fat. It has epinephrine in it that constricts blood vessels, and I'm not sure. I mean, lymphatics don't have smooth muscle in them, but so they probably theoretically are not constricted with the epinephrine, but they do run with the deeper blood vessels, and they're spared because they're functioning afterwards if you use tumescent fluid. There were two good studies done by a group of German doctors, I think 15 years ago or so. They used cadavers, people who had died recently. They injected dye between the toes, and they moved the leg back and forth for 5 minutes, bent the knee, which made the dye travel up the lymphatics, which is interesting. That means your lymphatics are even working when you're dead. So I think they're going to work after liposuction. But that's a digression. So they did that, and then they did liposuction parallel to the leg and perpendicular to the leg, and opened up the legs and found that the dye extravasated into the tissues when they went perpendicular. So they published a study that said you have to do liposuction on the parallel to the long axis of the leg. But then a couple of years later, they repeated the study and injected tumescent fluid into the legs and found that there was no difference, perpendicular or parallel, no difference. So the tumescent fluid even protected the lymphatics in a deceased person. So it's the tumescent fluid that protects lymphatics in people when we're doing liposuction. Is it difficult to work on someone who has had liposuction before because of scar tissue? It is more difficult. It's hard. It's more difficult surgery because, as I said, when you liposuction the area, a year later, if you feel your leg, it's going to be soft. It's not going to be hard, and you would think, well, there's still some soft fat in there. But when you go in to do revision surgery after liposuction, there's scar tissue, and it's hard to inject even the tumescent fluid, but it does go through. We have little cannulas that go through the scar tissue. And then I think the Vaser is really useful for this. It's a little probe that gives off high frequency ultrasound that vibrates tissue apart, but just the fat. It doesn't injure blood vessels, nerves, or lymphatics. So it helps vibrate fibrous tissue and scar tissue apart. So I like it for revision, especially because it kind of breaks up and emulsifies the tissue, makes it smoother, and makes a smoother result, I feel. And so it's more difficult, but it's not impossible, or having had previous surgery doesn't preclude doing revision surgery. We do it all the time. The woman I did today, I told you she wanted more fat taken out to put more fat into her buttocks. And I had done the liposuction previously, and I did the tummy tuck previously, and some areas were a little hard to get through, but it was not difficult to do, so it's very possible. What is my opinion on the differences between the wall, the PAL, the Vaser, for the treatment of lipedema? Which do I use? So I use the PAL, the power-assisted liposuction. It's a handle that the cannula attaches to the end with suction tubing, and the cannula vibrates in and out like this. There are other power-assisted lipo devices. One that's made by the Vaser company, which I don't love, that goes like this. It seems to be harder to me. It's almost like doing it without power, which is really hard. It's really hard on your shoulders and your arms. So most people use the power assisted, either this one or this one. I like this one. So the PAL works great. Tumescent fluid is the most important thing. The wall is water assisted liposuction, or the water jet. That is a device that both injects the tumescent fluid. So you're still putting tumescent fluid in, it injects it, and there's a mode that you can inject and suction at the same time. I think that's impractical because you want the solution to sit in there for a while and have its effect. Some people wait 20 minutes before they'll treat an area that's been injected with tumescent fluid. I wait about 10 minutes and it works fine. It's set up, that area is blanched, so we know the blood vessels are constricted. But if you're jetting fluid in and sucking it out simultaneously, I think that doesn't make sense. Most people that have the wall that I know use it for injecting the tumescent fluid. So it's a little sprayer. I use a pump, sprinkler type cannula. There are different ways to inject the tumescent fluid, and wall is one of them. I don't personally have the wall.
The body jet.
The body jet, sorry. I do like the Vaser for the reasons I just said. Vibrates, it emulsifies fat and fibrous tissue. I think it generates, I know it generates heat, and I think it heats up the undersurface of the skin and creates more skin contraction than I used to see with plain old liposuction or smart lipo that I did for about 10 years, and I was a trainer for the company that makes smart lipo. It's a little laser fiber. We used to go through the fat to try to laser it, and the laser fiber under the skin to heat it up, but it took forever, and the Vaser is much more efficient at both breaking up the fat and fibrous tissue and heating up the skin. So I do like the Vaser. Having said that, though, you don't have to use the Vaser. So number one, the Vaser is not dangerous. It doesn't injure lymphatics. I like it. I think the results are better. I think I get better results with the Vaser, even though it takes more time. It adds 10 to 15 minutes to each area because I'm applying that Vaser energy. So it's more time consuming. A lot of surgeons don't want to spend more time. They want to spend less time. So, I'm doing that and putting in the extra time. I think it's beneficial. It's not gimmicky. I don't get paid by Vaser. I had to buy the machine. We don't charge extra for it, but I do use it because I think the results are better. What is my experience with going in right up under and against the skin using Vaser to break up angiolipomas and lipomas? We can do that again. Again, I'm not, I mean, I'll be as aggressive as we need to be to treat a certain situation. If you have lipomas and angiolipomas that need to come out, we can try to break them up with a vaser and the power cannula. And if they're not coming out, sometimes you'll thin out an area and you can feel the skin and you still feel these little rocky nodules. Then we can make one or multiple incisions and pop those out, and they come out very easily. And we can put some little dissolvable stitches, and it heals very well. So that's the end of our questions. We went through 2 pages of questions.
Wow.
I hope that was good and informative. I'm happy to do this again. I like doing this, and so we'll schedule some more of these webinars more regularly. And I'm happy to talk to any of you individually. Contact Christina, and we can arrange that. And so thank you all for your interest and participation, and have a good night.
Thank you, Dr. Schwartz. I know it's been a long day, and it's so important for all these ladies to have their questions heard and answered by you, so we really appreciate it.
My pleasure.
Thanks. Night, everyone.
Good night, everybody.